Hi everyone, today we're back with another breast short review. What I have in front of me is Paget's disease involving the nipple, or Mammary Paget's disease, DCIS Paget's, lots of different ways to term this entity. This occurs in about 1 to 2% of all breast cancers, so that includes men and women. Often it presents clinically as a scaling crust or erythema that's often painful and can even be pruritic. So if the patient's scratching at the lesion and excoriating it, then it might even be a little oozy and owing a little bit as well to the crust. So this lesion often mimics infection or inflammatory conditions. And rarely it'll present as a pigmented macule. And usually all that means is that we have a lot more melanocytes involved with the lesion. This often arises in the nipple and areola, but it can also be seen in accessory nipples that occur along the milk line. And remember, the milk line goes basically from your axilla down into your groin. So if they have ectopic nipples, you can also see Paget's disease in that anywhere along that milk line. About half of these cases will have palpable masses, and it will be a palpable mass on the same side, okay? So you're not going to see Paget's disease on one side and have a mass on the contralateral, in the contralateral breast. But often the Paget's lesion is what presents initially, and the carcinoma is often incidental. Grossly, again, you may see that scaling, but often this is removed when they are prepping the patient for either the biopsy or for surgical excision. So don't bank on that. You can see erosion sometimes, again, if they've maybe been excoriating that, and you may even find a palpable mass, but usually these things will be indicated to you by the clinician, and if there's a palpable mass, often that has associated radiology with it. What's good to know about these lesions is that the margins are rarely involved beyond the clinical lesion. So what that means is if you have an area that's obviously scaly or excoriated, Paget's very rarely goes beyond that. So it makes for an easier assessment of the margins when the clinicians are going in to excise that. Let's get into the micro, though. That's why we're here, right? So what we can see here is that we have skin, okay? And obviously I'm over top of the lesion. So at 4X, what we can see is that there's something filling up the epidermis. We're not quite sure what it is, but these look like large cells. And just to kind of show you a comparison, we'll go over here and get in focus. And this is normal epidermis. So you can see that there is, even at 4X, there is a transition. So just to kind of set you up, we'll just go a little higher. And again, what we can see here now at 10X is that we have a very well-defined epidermis. It's not inflamed, it's happy. We have our basal keratinocytes are all in a row. And then we start seeing over to the right of the screen these very large cells that have very ample, pale to eosinophilic cytoplasm. But they don't really look too scary yet, right? So if we go even higher, and I apologize because now you're going to deal with my shakiness. What we start seeing is that even though at lower power these cells maybe didn't look too scary, we start noticing there's a little more pleomorphism with the nuclei, and there's some atypia going on here. We're not quite sure what. And obviously if we go along here, I'm probably going to make somebody motion sick looking at that. But we start to see more and more of these cells, right? So you can appreciate how they're more pleomorphic. Some of them have really, frankly, quite large, prominent nucleoli, which you can see. You don't have to see those prominent nucleoli, but they're often there. And something else that you can see usually using a special stain is your PAS-D or diasterase, PAS, and you'll find these resistant granules. And we can see, let's see if I can zoom in or at least get centered. Okay, it's not quite center, but we have a few of these very large cells that seem to have these vacuoles in them, or maybe granules, and so it's very possible that these would have those PASD positive granules, and what those can contain when they are present is mucin, okay? But you don't have to see them for Pagets, but it's just something that we can't see. And hopefully, again, just more very large, pleomorphic, somewhat hyperchromatic, but not always, nuclei, and those prominent nucleoli. And we can appreciate in this view how it's just taking over the epidermis, okay? We have single cells, and they're not just at the base of the epidermis, okay? We are going all the way up into the superficial layers of the epidermis, and that's really important to note because that's something that can help you with your differential. Something else that you can see with Pagets, and it's kind of in this area that where we're losing some epithelium, but we have this very superficial dermal infiltration of lymphocytes. If you aren't sure that these are lymphocytes, let's just go up a little higher so you can see they're very small, very little cytoplasm, and very, very dark nuclei. Like lymphocytes have nuclei that looks like someone took an ink marker and just stamped it down, okay? Those are your lymphocytes. Obviously, if you had erosions or even ulcerations, you could anticipate maybe there would be an acute inflammatory component to this. This case does not have that. Other variable things that you can see not present in this case include things like, is there hyperplasia of the epidermal layer? Is there hyperkeratosis? So those are things to keep in mind. If your epithelium was entirely replaced by Pagets, so entirely replaced means that when we're in a view like this, there's none of those small keratinocytes, and those keratinocytes are still present. We can still pick them out even at 10x, which is where we are now. But if it was entirely Paget cells, then the epithelium becomes extremely friable, and that's when you're more prone to these erosions and stuff. So if you're not really appreciating that there's complete replacement of the epithelium, then you're less likely to find the erosions, and the erosions often are very prominent, so you shouldn't have to hunt for them to see them. Okay, what else? So one of the things, and we'll get into this in the differential, but I just kind of want to go over this now since we have this view here, is that Toker cells are a normal part of the nipple, and they will look very similar to Paget cells. The difference is that Toker cells will not have those pleomorphic nuclei, okay? They are very bland. They don't have those granules filled with mucin. It's extremely rare for them to be positive for mucin. And they will be found in the basal layers and maybe the mid portion of the epidermis, but you're not going to see Toker cells in the superficial epidermal layers, okay? So those are important things to think about when you're looking at this. As far as IHC goes, we already talked about the PAS-D, which is a special stain, not IHC. Paget cells should be positive for low molecular weight cytokeratin. So what is that? That's your CK7, your CAM 5.2. Those would be favored. HER2 is almost always positive in Paget cells. So is EMA. You can see positivity sometimes in CEA or S100. Things that should be negative would be high molecular weight cytokeratin, so that's things like your CK56, your A13, your hormones, so ERPR tend to be negative in Paget cells. And if you're worried about, hey, is this maybe a melanoma? Remember how we said that sometimes these can be pigmented lesions. Paget cells are negative for melon A, HMB45, MART1. Pick your favorite melanoma stain, and that should be negative in your Paget cells. There's no real specific molecular to know because this is just an indication that there's something else going on. There's something more insidious in the breast. And your differential, as we have already mentioned, includes Toker cell hyperplasia. Again, the Toker cells should be HER2 negative, ERPR positive. so very different. And on rare occasion, they'll be CA or mucin positive, but generally negative for those. You can also think about, is this carcinoma directly invading the skin? Well, to have carcinoma directly invading the skin, you should see it. There should be a mass lesion. And it also tends to not have necessarily the same features. It's more likely to be ductal carcinoma or carcinoma of no specific type when we're looking at Paget's disease, but what would be an extremely difficult situation would be if the patient had a history of lobular carcinoma. Again, extremely rare. Toker cell hyperplasia should be higher up on that list. You could think about things like, is this a squamous cell carcinoma-in-situ or Bowen's disease type picture? And for squamous cell carcinoma-in-situ, you're not going to have the Paget cells. It's going to be your keratinocytes that are going to be abnormal. And so the presentation as well would be very different. The clinicians are more likely to see a mass-forming lesion, not just feel one. And that would also prompt you to go towards the squamous cell carcinoma in situ route. For melanoma, well, obviously, if you had a pigmented nodule, that would push you towards melanoma a little more. Your melanoma stains would be positive. So those kind of things would help you out a little more there. And there is also this clear cell change in keratinocytes that can happen. And clear cell change or glycogenation of keratinocytes often gives you more of a halo around the cells. Again, you're not going to have the pleomorphism, and it really tends to occur more in like the basal to mid epidermal layers again. So similar to like clear cell changes that you can sometimes see in cervical epithelium as well. For treatment, again, they're going to excise this, and they do have to excise the entire nipple, but remember, because there is a lesion that they can see, they often are very good at getting clear margins. And even if there is a breast mass, they often are able to do breast conservation with these cases. Your prognosis depends on if there's any associated cancer with this. If there's only DCIS or ductal carcinoma-in-situ, then your prognosis is basically the same as DCIS. So almost all cases, like more than 95% of cases, are going to survive 20 years. If you have an invasive carcinoma associated with this, then the prognosis really depends on the stage of the invasion, the lymph node status. So there's a high amount of variability with that. Again, more likely that this would occur with a ductal carcinoma or no specific type, but it can occur with anything. So one thing I do want to show you that was interesting in this case, going to a different slide here, is that this case was associated with a little bit of DCIS. So what I'm trying to show you here, get in focus, is on the left side we have the DCIS type areas. On the right side we have normal. Okay, so this is under the nipple, so you expect some dilatation. That's why you have muscle streaming through here, right? This is part of your lactiferous ducts. So when you do have DCIS in these cases, it's often high grade. It's often solid or comedo type. This is just involving, at least from what we can see in the case. Oh, sorry. It's just involving the nipple. So you would want to say that. So this would be worded in a way such as DCIS, give your grade, involving the nipple. You'd want to list your Paget's disease as well. Obviously, if you had invasive carcinoma, that would trump your DCIS. You would still want to say that's present, but your top line would switch. And because this is in situ, Paget's disease is in situ. So even if you have a punch biopsy, we're not going to do HER2, right? Because almost all these are HER2 positive. for Paget's, but you would do ER/PR, just like we would do for DCIS. And some institutions won't do PR, and that's totally acceptable too. So this is what I have for Paget's disease. So hopefully this is something that you found helpful. If you like this video, please hit like, share it on Facebook, on Twitter. I'm happy to hear anything you want to say about this video. Did I miss something? Is there something that was confusing that you'd like some clarification on? Are there things that you would like me to do videos on? And of course, if you aren't subscribed to us, then please hit the subscribe button so that you are notified when we have new materials out. And we will see you at the next short review.